The Truman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle presents its second annual conference, Ethical Issues Related to Vaccination of Children. The Truman Katz Center is the nation's first center dedicated solely to the study of research and healthcare for children. During this 5-part television series, national experts discuss vaccine policy, parental rights, and global controversies surrounding childhood vaccinations. In this program, Dr. Douglas Diekema, Professor of Pediatrics and Director of Education for the Truman Katz Center for Pediatric Bioethics, presents The Case of Vaccine Refusal, Parent Conviction, Child Best Interests, and Community Good. Dr. Diekema is introduced by Dr. Benjamin Wilfond, Chief of the Division of Pediatric Ethics in the Department of Pediatrics at the University of Washington School of Medicine. Dr. Wilfond is also the Director of the Truman Katz Center for Pediatric Bioethics.
It's my pleasure to introduce our next speaker, who is Doug Diekema, who you've had a chance to hear from yesterday as a moderator, and today you'll have a chance to hear him giving some more of his thoughts. In addition to Doug having organized this conference, the issue of immunization refusals is an area that Doug himself has thought a lot about and was instrumental in having the American Academy of Pediatrics Committee on Bioethics, which he's now the chair, think about this issue in more detail, and they had a publication that came out several years ago on this topic. Additionally, on a personal note, I've known Doug for 20 years. We were residents together in Wisconsin, and I look forward to hearing your comments today. Thank you, Doug.
Thank you, Ben. My career actually started when I was in my single digits, and it's somewhat related to this cartoon. Because this was my grandmother's worst nightmare. We would spend a couple weeks every summer visiting Grandpa and Grandma in northwest Iowa, and usually at some point during the visit, Grandma would announce that we were going to go to the big city, which was Orange City, Iowa. And she would require that we put on a new, clean pair of underwear in case we got in an accident. Now, what does that have to do with ethics? Well, this resulted in some of the first ethics or values-based debates we had in my family. Grandma was appealing to the Calvinist virtue that cleanliness is next to godliness. And we, particularly as we got older, we got much better at articulating our claim that stewardship was also an important value for Calvinists, and that if we were going to get in a wreck and lose a pair of underwear, it ought to be one of our ratty, dirty pairs, not one of our nice pairs. So that's how I got started. This is Jenner vaccinating his neighbor, 9-year-old James Phipps. It's not actually Jenner, it's a picture of Jenner. And we've heard this morning from a couple of people now about how successful vaccination has been and the major impact it's had on pediatric disease. And so I'm not going to spend a lot of time expounding on that anymore because it's been done so very well. But in sort of setting up my discussion, I want to make a couple of sort of general points that I think are important in at least maybe adding some clarity to discussions about whether parents should be allowed to refuse vaccinations and how pediatricians should respond, pediatricians and family practitioners and nurse practitioners and others who take care of kids should respond when they're faced with a parent who's hesitant about vaccinating a child. Point number one, as sort of a lead-in, is just to recognize that vaccine policy has more than one purpose, and I found that in these discussions it's easy to lose sight of the fact that vaccination is not simply about protecting an individual from disease, which is usually a parent's main concern. Is this protecting my child against disease? But from a public health perspective, from those who work at the Centers for Disease Control and the Department of Health in the state of Washington, and for many of us who sit in pediatricians' offices, we also recognize that there's this very important public health impact that vaccination has. That can go as far as eradicating disease from a community, as has occurred with several diseases like smallpox and polio and others. When we talk about vaccinating children, that's important to remember, and for reasons Ed talked about, which is that the language we use when we talk to parents is going to depend a little bit on how their focus may differ from our focus from a public health perspective. I see really three issues here, and again, I see these get mixed up frequently in the discourse about whether parents should be allowed to refuse vaccination. And I think there are three, and there may be more, but these are the three I want to focus on, ethical issues that come up. The first question is, do parents have a duty to vaccinate their children? And I'm not going to spend a lot of time on that question this morning. I'll give you my short answer, and my short answer is I think parents do have a duty to vaccinate their children, and it's not solely a duty based on what is best for their own child, but I think there are community responsibilities, and that no matter how you come down in terms of your answer to the next two questions, it doesn't change the fact that there is this sort of ethical obligation that is sort of out there. The second question is the one I'll spend more time talking about, and that is whether or not you think parents have a duty to vaccinate their children. Under what circumstances should parents be required to vaccinate their children? And then finally, what should a pediatrician's response be toward parents who refuse vaccination? So it's these latter two questions I want to talk about. And the main reason I show this slide is just to make it very clear that one answer doesn't necessarily settle the answer to another question. And I found that that's one source of confusion that many people have. They assume that if there's an ethical obligation to vaccinate your children, then it's okay for the state to require it. That may not be the case. The second sort of general comment I want to make is that what I found is many people in bioethics, and it's not necessarily the case of the people in this room, but when the sort of issue that is representative of a parent not wanting to follow recommendations regarding vaccination comes up, I found that the common way to characterize that from an ethical perspective is to say, oh, this is a classic conflict between autonomy and beneficence, with autonomy being the principle that says we should respect the desires and wishes of individuals as long as those desires and wishes don't interfere with the freedoms of other people, and beneficence being the principle that says we should basically do what's best for others. My contention is that this debate, this discussion, if you want to characterize it in terms of ethical principles, is really about beneficence. It doesn't have to do with autonomy. Technically speaking, autonomy is about self-rule. It's about an individual's ability to make decisions for themselves. And when we're talking about childhood vaccinations, we're talking about a parent making a decision for a child, not a parent making a decision about their own health care or a child making a decision about his or her own health care. Beneficence is this principle that says what we should be trying to do in situations like this is what's best. It's the obligation to seek the good of others, to avoid inflicting unnecessary harms, to prevent harms, and to promote the good of the individual. And I think everybody would agree that medicine, nursing, all of the medical professionals, public health, is a form of applied beneficence. What we're trying to do in all of those fields is apply this principle and come up with what ultimately is the best for the individuals involved. The point I want to make is that so is parenting, that this debate is not a conflict somehow between a parent's autonomy and the beneficence of the medical profession in terms of trying to get that child immunized. This is a conflict about what beneficence means in this particular setting. It's a parent who really and truly is genuinely trying to do what's best for their child, and they just happen to disagree with the medical profession, with public health, about what that might be. Why is that important? It's important for some of the reasons Dr. Marcuse mentioned, which is to recognize that when we talk about conflicts about how to interpret beneficence, we're talking about values conflicts. Data won't necessarily solve that problem. Now, as my mentor Norm Foss says, good ethics requires good facts, and so data informs this discussion. But the bottom line is that beneficence can be perceived in different ways. This principle of doing what's best for an individual child or even the community can be perceived in different ways. And as we try to solve this problem, to come to consensus, to come to agreement, perhaps to have a respectful discussion with a family, it's important to recognize that this different way of seeing what may be best for a child exists. Although we may be sort of looking at the same set of facts, it can look very different, as this photograph sort of demonstrates. These two photographs I took within 2 minutes of each other, and they look like completely different places. I'm not going to talk about the obligation to be honest this morning, but this leads into what I want to focus much of my time on, and the way I'm going to structure the next, the rest of the talk is first to talk about this notion of and my sort of way of thinking about when the state can tell a parent that they need to be immunized, and then I'll spend some time talking about what pediatricians should do. And I'm going to end with a couple of slides that talk about public policy. My way of thinking about this discussion is, first of all, to recognize that physicians, nurse practitioners cannot make a family do something they don't want to do. The power to do that lies with the state. And so one misconception people have is that the hospital or the physician somehow can make a family get immunized, can make a family in other situations undergo a certain treatment. That's not the case. If the family disagrees, it would be a battery to do that unless you have some authority from the state to make them do that. So that's point number one. Now, what that says to me is that the structure within which we think about this needs to be the structure within which we think about laws in general. And we have a philosophy of thinking about the way laws should look in a liberal democracy. And I use that term in the sense it's supposed to be used, not in the sense of the way liberal and conservative have been distorted in our current discussions. The United States is a liberal democracy, and it's founded largely on principles of authors like John Stuart Mill, who wrote in On Liberty that the only purpose for which power can be rightfully exercised over any member of a civilized community against that person's will is to prevent harm to others. His own good, either physical or moral, is not sufficient warrant. I would argue that the way this sort of notion should be applied in the immunization setting is to think about the person we're talking about exercising control over as the parent. And the parent has made a decision. And in order for the state to intervene, we need to make the case that somehow the parent's decision is harming somebody else. That is how you justify a law that would infringe upon a parent's ability to make decisions for their child. So when is it justifiable to restrict individual freedom? First of all, I would make the argument that the first criterion is that the action or decision made by that parent needs to place another individual at substantial risk of serious harm. Not a remote risk, not a trivial harm. We let parents make those sorts of decisions all the time. The example I like to give is when I plop my kids in the car and drive down Bothell Way to get a drink at Starbucks. That's not in their best interests, and I'm putting them at potential risk. Just putting them in the car and driving down Bothell Way probably puts them at more risk than climbing a mountain around here. And yet I'm doing that because I have a need or a desire. We don't expect parents to sort of minimize every activity simply because it might potentially harm their children. We have a threshold, and that threshold is usually something like a substantial risk of serious harm. So in my scheme, this would be sort of the standard that needs to be met. Secondly, if we're going to restrict a parent's ability to make decisions for their children because we think their decision places a child at substantial risk of serious harm, it's important that whatever restriction we choose be effective in preventing that harm. And in the immunization situation, the argument you would have to make is if you feel a child is being placed at significant risk of serious harm, then you need to also be able to make the case that the immunization will prevent that. And that part of the equation is often fairly easy to make because we have good data for almost all of the vaccines, at least the ones that are recommended, that is actually the case. Finally, the least restrictive alternative needs to be used. In other words, if there are other alternatives short of forcing a parent to immunize their child that would be equally effective at preventing that substantial risk, or at least reducing it to the point where it's no longer substantial or where the harm is no longer serious, that option should be the one chosen. And this requirement may point to the importance of dialogue, because it may be that compromise in some way can achieve this. And we'll talk a little bit about that in a minute. But these are the three basic criteria that I would argue need to be met in order to tell a parent you have to immunize your child, for the state to say that. I think there are two ways the state can be interested in whether not immunizing a child places others at substantial risk of serious harm. And this is another important distinction I want to make, because the state may have two reasons for making that case. The first is the one that most parents are interested in, which is they can make the case that by not immunizing a child against a certain disease, that child as an individual is being placed at significant risk of serious harm. But the state can also potentially make the case that by not vaccinating this individual child, the parents are placing others in the community at substantial risk of serious harm. And again, the standard is the same. It's not small risk, it's not trivial harm. It has to be a substantial risk of serious harm to really justify a coercive policy, a policy that requires a family to get immunized. So let's look at the first one first, which is harm to the child. Can the state, in most cases in the United States, make a case that we can require children to be immunized for their own sake? The important thing to remember here is again, that the parental right to make these decisions is much more limited than the parent's right to make decisions for themselves, because parents are deciding for somebody else, and it's the child that ultimately will bear the burdens and the benefits of the treatment. And that's one of the reasons the state has a right to intervene here. They can't tell a parent to get immunized for that parent's sake, but they can potentially tell a parent to get immunized if they can make the case that the child is placed at substantial risk of serious harm. So the best interest question, or the harm question, is whether a parent's decision to refuse to vaccinate the child places the child at substantial risk of serious harm. And the answer to that question is it's going to depend on these factors: disease prevalence, the rates of immunization within the community and how herd immunity works with some antigens, the mode of disease transmission, for example. The equation here may differ for tetanus, which you get from spores in the soil, than it does for polio, which you have to get from somebody else who has to have that virus. Potential contact with the disease agent, the morbidity of the vaccine, and the severity of the disease being prevented. There are some diseases it's much easier to make a case for than others. For most vaccines, however, in the United States, where immunization rates are sufficiently high to create at least some herd immunity, it's not entirely unreasonable for a parent to make the argument that because others are choosing to get immunized, I'm not putting my child at significant risk of serious harm by refusing to immunize my child. And I think we need to recognize that fact, whether we like it or not. To a certain extent, that argument can be made precisely because our vaccine strategies have been relatively successful. This equation changes dramatically if you have a disease outbreak. And it's in the disease outbreak situation where the state has a much stronger case in terms of immunizing children against a disease for their own sake. In my mind, this was most vividly and best illustrated in the recent past by the whole smallpox issue. As many of you are aware, one of the first sort of steps that was taken after 9/11 was to sort of develop a policy where we would try to get healthcare professionals to vaccinate themselves against the smallpox virus. And the smallpox vaccine carries a little higher risk than a lot of the childhood vaccines. What was fascinating about that experiment was how absolutely difficult it was to get healthcare professionals to vaccinate themselves against smallpox. Why was that? Most of these were people that had vaccinated themselves against everything and that are the first in line for influenza, people like me. And yet there was no way I was going to get vaccinated against smallpox. Why not? I would suggest that the simple answer is that the disease prevalence is 0. Now do a thought experiment. If during that time we had had 1 case of smallpox appear in the United States, I will guarantee you we would have had healthcare professionals and everybody else lining up for that vaccine. These are not irrational decisions. It shows you people do figure these things into their calculations about whether to vaccinate themselves for their own sake. And it's important to recognize that when we talk to parents, because many of them are not being irrational about their concerns about vaccinating their child necessarily. It may be that they're weighing things differently, and it may be that they're dealing with faulty data at some times, but many of them are doing these calculations in their head or as best they can. So I would argue that as disease within a well-immunized population becomes rare, parents may have an interest, or at least they may believe they have an interest in avoiding vaccination for their own children, for their children's sake. And it's, as I've pointed out, state intervention in that case really is only justified if you can somehow make the case that that child is still at significant risk of serious harm, which can be difficult to make short of an epidemic situation. So when could that case be made? Well, when disease prevalence is high and or immunization rates are low, that may change. If, for example, we have a resurgence of polio and people aren't getting immunized against polio, the state now has a very good reason for making the argument that parents who don't immunize their children against that disease may be placing them at significant risk of serious harm. On the other hand, when disease prevalence is low and or immunization rates are high, it's much more difficult to make that case. And I would argue that, that in many cases, that case can't be made for the child's own sake. One of the things that we should probably be encouraging parents to do, however, is to think about long-term interests as well as short-term interests. Parents usually think about the short-term interests. They think about the potential risks of vaccine and how my child isn't likely to encounter somebody who's got measles or mumps or polio. But one strategy that physicians and nurse practitioners and so on might use in their practice is to point out to parents that this 5-year-old at some point is going to be 20 or 18 and they're going to want to go to Mexico on that Habitat for Humanity trip or the interim abroad. And at that point in time, they are going to be potentially in places that do have these diseases that are endemic and will be unprotected, and it presents a bit more of a challenge at that point in time. Although that may not sway many parents, it may sway some. Now, one of the things that's important to recognize here from an ethical perspective is that this does present what we call the problem of the commons. The problem of the commons originally refers to a situation where you've got a common grazing field and all of the farmers in the area are grazing their cattle. Every farmer has an interest in nobody overgrazing so that there's enough grass for each cow. But every individual farmer actually has an interest in overgrazing their cattle. But that'll only work as long as everybody else is not overgrazing. And that's really the problem that's presented with the vaccination issue. So, and this is why I would make the case that even though we may not be able to argue that we should have a coercive vaccination strategy for children's own sakes, that I would argue that there is something morally wrong about a parent choosing not to immunize their child. They are really taking advantage of the fact that most parents are willing to do that and subject their child to what they perceive as some risk of the vaccine. So in a very real sense, they're allowed to make that decision precisely because they can be free riders on on the decisions that other parents are making. And that does present a moral problem, even if it's not sufficient necessarily to justify a public policy. So let's talk about the justice question, because as I pointed out, the harm principle would actually allow the state to intervene in a situation where the public health is being put at risk because a child's not vaccinated. Is there a duty to prevent harm to others in the population? And as I've just argued, I think parents do have that duty, that personal ethical duty. And the state obviously has an interest in making sure that an individual child isn't placing others at risk. So, as I've argued, I think individuals do have a duty not to impose harm on others, and there are ethical principles that clearly outline that responsibility. Vaccination programs exist to reduce harm to those within the population. So, I mean, the public health perspective is that we're not vaccinating just simply because children will benefit as individuals, but because they will benefit the community as well by being immunized. And again, Dr. Kachi showed some nice data related to the pneumococcal vaccine, how vaccinating children protects our elderly, for whom pneumococcal disease is a very big problem. Do I, as a parent, have a responsibility to make sure my child doesn't put elderly people at risk from pneumococcal disease? I feel I do, and I think I can make a case that most parents have that ethical obligation. Those who refuse vaccination may put others at risk of harm, including those participating in a vaccination program. And that's an important point, because one of the arguments somebody might use, if I'm talking to a parent and they say, well, I don't quite get the whole argument about why I should vaccinate my children for the sake of others, because if they want to protect themselves, they can get vaccinated. And it sounds like a perfectly coherent argument. The problem with that argument is that every vaccine has a non-take rate. In other words, there's a certain percentage of people who, despite the fact that they're fully vaccinated, are not actually protected against disease, unbeknownst to them. And so they're potentially being put at risk by unvaccinated individuals in the community. Perhaps more importantly, there's this group of kids and this group of people who are immunocompromised, being treated for cancer, who can't be protected against some of these diseases in any other way than through herd immunity, by protecting those who surround them. And I think that can also be a powerful claim, if not morally, even potentially from the state perspective, particularly when you've got a school setting or a daycare setting where these children are mixing and in close contact. We know that people who exempt from vaccine do put others at, not only put their own children at risk, but do put others at risk. In one study, exempters from the measles vaccine were 35 times more likely to contract measles than vaccinated individuals. So it's not the case that these children, that their parents' decision isn't potentially putting them at risk to develop measles. I'm not convinced in most cases that crosses the threshold of substantial risk of serious harm. But there is some risk there. But the other thing that's important to recognize is these same studies have shown that the outbreaks frequently, although they begin with the exemptors, and you could argue that, well, you know, it serves them right, if you wish, but then that disease does spread to those who have inadequate vaccine protection in the community. And so there is harm being done even to those who have tried to maximally protect their kids by vaccinating them against disease. It's true that the most likely to be harmed are those refusing vaccination, but as I've mentioned, these other classes of kids are also being affected, which does have public policy implications. So as I've argued, it may be the case that some kind of state intervention can be justified when there is good evidence that others in the community are being put at risk by a parent refusing to vaccinate a child. Most of the time, that's also going to be a hard case to make because disease prevalence is so low. It can be hard to make the case that one parent not vaccinating their child places others at substantial risk of serious harm. That equation may change, though, when vaccination rates drop below 80, 70, 60%. State action still has to be effective at preventing the harm, and as I've pointed out, usually vaccinating a child is effective at preventing this harm to other people. But then the other thing that's important to recognize is that no other options less intrusive to individual liberty be available. And I think that's an important one when we talk about state, at least coercive state requirements to vaccinate children. What a lot of the data from Europe shows is that to a certain extent this becomes self-regulating. That because when vaccines are successful, you actually do get increases in exemption rates. People are taking advantage, they're free riding, they're taking advantage of the fact that disease incidence is low. However, once you get to the point where the exemption rates are high enough that disease prevalence increases, as long as the media pays attention to that and people start reading about pertussis outbreaks, measles outbreaks, and so on, you get an increase in vaccination rates, which I would argue is parents acting rationally. Those people who some of those people who previously exempted now recognize that my child is at an increased risk than they were 2 years ago, and therefore I'm going to get them vaccinated. And one could argue that in most cases, at least as long as there's media attention and people are reading about the disease outbreaks, this can be self-regulating and may not require coercive state intervention. During a disease epidemic that's serious, state intervention I think can clearly be justified. But as I've pointed out, in most cases it's probably at least coercive state intervention is not justified. Given that, what's the physician's obligation? I've already pointed out that absent state authority, the physician can't treat or vaccinate without parental consent. And my argument would be that state agencies should not, in other words, child protective agencies, should not be involved simply because a parent refuses to vaccinate a child unless there's good evidence that that decision is placing the child at substantial risk of serious harm. In my own practice in the emergency room, the only time this ever really raises its head is when I've got a child who has a dirty wound and they're completely unvaccinated against tetanus. And in that case, I have to struggle with this issue. Does this constitute child neglect? Is the risk they're placing their child of contracting tetanus, which everybody would agree is a serious risk, so the only real question is what is the actual risk of having a dirty wound and then contracting tetanus? Does that cross this threshold? I don't have an easy answer to that, but what I can tell you is from my own experience, I've never been unsuccessful in that situation in convincing a parent that they should voluntarily vaccinate their child. What they really need to hear at that point is, your child is at risk for tetanus. You've got a dirty wound, that's where the tetanus spores reside, in dirt, and you don't want to have your child go through tetanus. At that point in time, the equation changes for them, and I've found I've never had to call Child Protective Services in order to sort of get accomplished what most people would agree in that situation is necessary to prevent harm or potential harm to the child. So most of the time, respectfully continuing to work with the family is going to be important. With the routine vaccination schedules, I would make the same argument that the first important step is to understand why a parent is refusing the vaccine. As Dr. Marcuse pointed out, there are lots of reasons parents have hesitancy about vaccinating, and not every parent is the same. And so you can't treat them as sort of this homogeneous group. There are some parents that have beliefs about the immune system and the impact of vaccines on the immune systems. There are others that just don't like their child looking like a pincushion. And the strategy you use is going to differ between those two groups. If it's the pincushion issue, you can often negotiate a schedule with the parents that doesn't involve multiple injections. It may not quite follow the exact schedule that we've laid out, but you can accomplish the goal of complete immunization if you're just willing to see them a little more frequently, more office visits where they're getting 1 poke at a visit instead of 3, or whatever may be required. Joel Frater is going to talk a little bit more about the whole issue of how physicians should respond and whether they should be firing families from their practices. The comment I wanted to make here is that physicians don't have, the physicians who do this don't have bad reasons for doing this. What frequently is the case is that their way of seeing this issue is that I'm in a field that has been impacted more by vaccination probably than anything else, with the possible exception of sanitation. And it's core to pediatrics. This is how we protect kids, and nothing we do protects them more than vaccinating them, at least as a class. And And so that pediatrician is going to argue, or that family practitioner or nurse practitioner is going to argue, if the family disagrees with me on something that's so core to my identity as a pediatrician, maybe I shouldn't be taking care of them. And there's nothing sort of unreasonable or irrational about that. But I would argue that it's a self-defeating sort of approach to the problem. Because what you've essentially done is you've cut off any potential dialogue with the family. It's unlikely to accomplish the goal, which you have, of getting that child vaccinated. It may further harm the child if their ability to seek another practitioner is limited, either because you're in a rural area, or if you consider yourself to be a good physician in terms of providing care for children, and the only option is for them to see people you don't think take as good a care of kids in the community, which I'm sure is the way you all feel, then you're potentially furthering the harm of the child. That parent may actually drive the parent away from organized medicine. I mean, they may feel so disrespected and so mistreated by having been asked to leave your practice that they will now get care solely from a naturopathic physician or an alternative medicine physician or nobody, which does not do that child good. And so I would argue that in almost all cases, continued dialogue shows concern for the child, it shows respect for the parents, and will work. Now, are there exceptions? I would readily admit that there may be exceptions. There may be some parents, not solely based on the vaccination issue, but where every encounter with that particular physician is a negative one. And every encounter, this sort of distrust comes up. And at that point in time, it may be worth, at a minimum, and again, I would argue against firing the families, but maybe at that point in time, the discussion with the family needs to be about whether I'm really the right doctor for you, because you don't seem to take any of my recommendations seriously. And that's an important discussion to have in those cases. But again, it's important to show respect. I think one of the points I want to make, though, about this dialogue, and one of the things that it's really important for physicians to recognize, is that the problem is usually that parents who don't want to immunize their kids are seeing the issue really differently than we're seeing it. They understand vaccination differently, and it may be that that's based on flawed data. It's maybe that it's based on something they've read that has no scientific basis. But the real key to being able to work with those families is to try to understand them. This is the shiprock, which is an impressive structure in the deserts of New Mexico. The shiprock rises 1,700 feet off the desert floor. You can see this 70 miles away from the Mesa Verde Plateau. It's the only thing that sticks up in the desert at that point. It's the core of an old volcano. And it has a lot of interest to a lot of people. Obviously, geologists are interested in it because it's the core of an old volcano. My interest is in photographing it. That drives my behavior. I see this as a photographic opportunity. So I see the shiprock, and my response is to drive around it like a maniac, trying to find the right lighting, the right angle, when the sun is going to be at the right place, when I need to come back to take that picture. This sits on Navajo land. The Navajos see this as a sacred mountain. It's one of their 4 sacred mountains. They think this is the remnant of a vessel that rescued them from their enemies and brought them to their current homeland in Arizona and New Mexico. To the Navajos, this is a sacred mountain. Look at those fluted walls. This is an icon for the rock climbing community. To the rock climbers, this is a challenge. The problem is the rock climbers find themselves at odds with the Navajos because you don't climb a sacred mountain. So we have an ethical dilemma. You don't really tell a rock climber not to climb something like this. It's against their nature. And you don't tell a Navajo that you're going to climb it anyway because it's disrespectful. What's important to recognize, though, about that debate is that if you're going to solve that issue, and it may not be solvable, but if you're going to solve that issue, you're not going to solve it by having a debate about science or a debate about facts or a debate about what I want. The only way to solve that issue, or at least get to the root of the problem, is to understand that for those groups of people, when they look at the shiprock, they see something very different than what you do. The rock climber sees a challenge, Their response is to make a beeline for the mountain and climb it. The Navajo sees a sacred mountain. Their response is to stand back in awe. And I see a photographic opportunity, so while they're doing that, I'm driving around it like a maniac. Our behavior is driven by what we see when we look at that mountain. And parents' behavior is driven by what they see when they look at the vaccination issue. The best hope we have for convincing parents that our view is the right one is to show some respect and to try to understand what it is they're seeing when they look at the issue so we can address that issue directly rather than try to pummel it out of them. A little bit about green eggs and ham, and this is borrowed from an article in the Hastings Center report, which I've referenced at the end. But I think it helps us understand why certain approaches with parents are better than others. Those of you who have small children recognize that green eggs and ham captures that experience. Do you like green eggs and ham? Dr. Sam I Am, who's sitting in the bottom corner, offers his patient green eggs and ham, and apparently to immunize him against certain diseases. And the patient says, no, I don't want it. I don't like green eggs and ham. I have no interest. The doctor persists, doesn't give up. Well, how about here or there? How about, on a goat or with a goat, as if that would be appealing. But, you try what you can. With a fox in a house, et cetera, et cetera, et cetera. Something like 89 times in 17 different scenarios, the physician has tried to get this patient to accept green eggs and ham. And the patient refused 89 times, which is fascinating because at the end we found out the patient actually likes green eggs and ham, and not only likes them, but thanks her doctor for giving the green eggs and ham. So what are the lessons here? There's 3 lessons here which this author pointed out. The first is that consistent preferences do not guarantee an understanding of what is at stake. Simply because a parent refuses to immunize their children doesn't necessarily mean that they really understand what the stakes are and what the issues are. And that's where respectful dialogue can be helpful. Number 2, certainty about one's preferences increases as one is repeatedly challenged. Now, if most of you look at your own behavior, you'll recognize this trait in yourselves, right? Many of you have been in arguments with somebody, and at some point in that argument, you have the very disconcerting experience of recognizing that this other bonehead is right and you're wrong. But at that point in time, they're so confident and so arrogant that there is no way you're backing down. Those who try to immunize children need to understand this important trait in many of the parents they're dealing with. It will frequently be the case that continuing to come at a parent, at least without showing any recognition that you understand and appreciate their concerns, is going to be a completely ineffective strategy. They will just become more and more entrenched. They will feel more and more disrespected. Now, that doesn't mean continued discussion is wrong, but the continued discussion has to be coupled with the recognition that you understand that they do have concerns and you understand where they're coming from. So I would argue that the first rule here is don't force it. That's also the first rule of bike repair, which is what this ad was illustrating. That Sam I Am, I do not like that Sam I Am. Now, Dr. Seuss actually showed us what the problem was on page 1 of the book. It wasn't that the patient didn't like green eggs and ham, it's that the patient didn't like his or her doctor. And that may be the problem in some of these cases, and that may be the situation in which it's important to have a discussion with a family about whether, from their perspective, they really feel that you're the right doctor for them. My argument would be that that discussion should rarely be just about the immunization issue. That's usually going to be the case when the family is opposing almost everything you're recommending, and it clearly doesn't look like a good match. And again, I don't think the answer is to fire the family. I think the answer is to have a discussion and point out to them that this seems kind of unusual, that they have chosen you as their doctor, and yet they don't seem to want to follow any of your recommendations regarding anything. All right, with that being said, I wanted to make just 1 or 2 comments about public policy. Talk is cheap. At At present reimbursement rates, the cost of providing immunizations barely covers the cost to practice, to many practices of administering them. And providers are increasingly likely to refer patients to public health agencies for vaccinations. We need to recognize that that's a barrier to getting immunized. I mean, many of these families, sending them somewhere else is enough to not have them go anywhere. They may have to pay for the bus fare. There may not be a bus that goes there. I mean, many of us don't recognize just how these small things can be a hurdle for many families. It's also the case that despite the fact that we make the argument that anybody can get vaccinated for free, that it's not quite as easy as it sounds. For many of us who are actually capable of paying for our vaccines, the substantial cost may be enough to convince us that I'm not going to vaccinate my kids. That point became very clear to me several years ago when I had insurance, ironically, as an employee as a pediatrician provided by my workplace that did not cover vaccinations. And when my daughter first started going in for these visits and I started getting these bills, it was unbelievable. I mean, it became very clear that that first 5 years of her life was going to cost me over $500 to get her vaccinated. At that point in time, I actually found myself thinking, do I really want to do this? I mean, that's $500 I could spend somewhere else. And when we put parents in that kind of a position, focusing on whether they're uninsured or underinsured is not the question. We've created a huge disincentive, even for those who are insured but don't have insurance that covers vaccinations or may have co-pays, and we've put those who don't have insurance and have to pay out of pocket in a position where they now have to make a market decision. Just like when they decide to buy the Oreos in the store or the car, they're going to decide whether to them this is cost effective. I'm not sure that's the kind of choice we want parents to be making. If we really feel vaccination as a society, as a community is important to public health, it's not clear to me that we should be making this a market decision that parents have to make in at least some settings in the current world. And I would suggest that the way sort of insurance coverage is going, that this is going to become an increasing problem as insurance coverage drops and becomes less and co-pays go up, and we're starting to see that pattern. Here's my feeling. Vaccination programs are important to the public health, and they're a community good. The biggest value of vaccination is not to the individual who gets vaccinated necessarily, and there are exceptions to that. Tetanus is an exception. But they're due to the fact that by protecting the community, we protect everybody. This is a community good. It's very different than somebody who steps on something sharp and needs sutures, where you're doing it for their own individual good. This actually benefits the entire community. I would argue that benefit of vaccination programs are shared by everybody, including those who choose not to get vaccinated, and yet those who choose not to get vaccinated don't have to pay the costs of the vaccination program, of what other people are paying in terms of insurance, in terms of out-of-pocket costs to get vaccinated. Therefore, I would argue that the burden of, and furthermore, the burden of vaccination programs, which I would argue is low, but we know that there are some side effects to vaccines, should not be borne exclusively by individuals participating in the vaccination program. What are the implications? I think all vaccination should be provided at public expense. We can argue about what's workable in this country, but I would argue from an ethical perspective that you can make as clear a case for vaccination as for anything, that this is just something that ought to be covered across the board for every citizen in the United States without playing these games about whether you're on Medicaid, whether you're underinsured, whether you meet the criterion. It ought to just be something that we cover because it benefits everybody. I mean, you can make, what better way to make a tax-based argument than to make the argument that it benefits everybody? This is like national defense in that sense. There ought to be adequate compensation for losses and health care related to any vaccine-related injury that should be provided for the public, and we do have that for the most part in place in this country. And as I've mentioned, we ought to have a tax-based system of compensation. And I would argue that you could even go further and argue that we ought to have a tax incentive to participate in vaccination program that levels the playing field for those who are willing to vaccinate their children as opposed to those who don't.
During the panel discussion that followed, Dr. Lainey Friedman Ross was asked if childhood vaccination should be mandatory or optional.
in the long run.
Lainey, would you make it voluntary entirely, or are you suggesting a tiered approach? We pick the most important vaccines, make those mandatory, then we have a set that's recommended but voluntary, and then another subset that.
Yeah, I'm not sure I'd even go there, because my problem with that, Doug, is because although we all agreed today on which ones we would really call mandatory, I think there'd be a lot more disagreement. I would make it a mandatory request that, in a sense, it would be medical malpractice for me not to offer it to my families, sort of like what California did with the AFP, which was totally inappropriate, but the whole notion of a mandatory request, and therefore documentation of refusals, and documentation of renegotiation, reconversations over a period of time. I think during the conversation, I would be very clear that here are some, like hepatitis B, that if you wanted to delay till age 8 or 10, you're not even gonna get a fight from me. But if you're not going to accept the DTaP and the Hib at 2 months of age, here's why I'm gonna sit here and keep talking. And so I think parents would hear the tiered level because of the way I would explain things. And then I'd also explain to them for their own convenience, they'd rather have that hepatitis B now, because trying to bring a 10-year-old in who's crying about immunizations is a lot more difficult than doing it when it's acceptable to hold them down at 2 months of age.
So you'd do away with school entry requirements
I would.
entirely?
Well, I certainly wouldn't go that far. And for good reasons. You know, I really know, I mean, we can't deny it, that uptake is significantly influenced by mandates. And
So Massachusetts.
We have protections. We do have environmental protections as a result of doing so. And at the same time that I say that, I don't think we should be putting the emphasis as much on who's not being immunized as the number of people who are being immunized. Now, if we were to remove that away from the mandate, it'd be interesting to find out how far it would fall, but I'm not ready for that risk. I'm not ready to take that risk. In other words, I do believe that we're just putting a lot of emphasis on the downside of it, when the majority of the people are getting their kids immunized.
So
I don't think we talk about that enough.
So Massachusetts has a mandatory newborn screening, like all of us do, actually only 48 of the 50 states. Mm-hmm. And in the past few years, they introduced hand-to-mask spec, not as a mandatory program, but as a research protocol. And as a research protocol, they were able to get, with voluntary consent, 98.5% uptake. If we told families that this wasn't research, that we thought there were real clinical benefit to the additional 28 tests that they wanted to offer in that community, if we can get 98.5% as research, I think we could probably get 99.5% as a clinical therapeutic maneuver. And I don't think we need to make it mandatory. I'm going to say what I said yesterday. Parents aren't dumb. If you explain to them that you're protecting their kids, they're going to accept this. And those who aren't often have their political, their philosophical, their religious reasons, and those are the people we need to work with. But the rest of the community is going to accept it, particularly if we make access reasonable, access affordable, and I'm going to go and agree with Doug, and we made all vaccinations free. That would take away lots of the barriers.
Yeah, we've covered a lot of ground here very quickly, and I'd like to. And I would like just to contrast the individual health and the public health perspective, particularly around hepatitis B. So you say we just do it in the newborns because it's easier for us. But then we come back to, since we do a very bad job of screening pregnant women to be hepatitis B, find out whether they're hepatitis B carriers or not, part of the rationale for a universal program is to protect infants against acquiring the disease in the newborn period and going on subsequently many years later to get liver cancer. So part of the equation that you have is how many cases of liver cancer are you willing to accept in order for a voluntary system? So there are other arguments, is what I'm trying to say.
Lainey, I'd challenge you on your analogy. I think I don't think it's much of a leap for a parent to go from what the single heel stick for newborn screening to adding 28 other tests without any further intervention in terms of their child getting additional sticks, as opposed to the vaccination situation where, I mean, your numbers, you showed how many pokes that is over the course of the first 3 years. So I think when parents look at vaccination, I don't think you can sort of infer from a 98.5% uptake of adding 28 additional tests to what you're already doing, which is a single heel stick, to what's happening in the vaccination arena.
So when a mother says to me about their 2-month-old, so will this shot hurt? Will the shots hurt? I said the first one will hurt, the second one will hurt, the third one will hurt, the fourth one will hurt, and the fifth one will hurt. But the good news is they're already crying, so you're not going to be able to tell which one hurt most. I mean, the fact is, once you're already giving one vaccine, you just give them all. And when parents think about it that way, so the kid's going to be unhappy. And in some ways, the parents who say to me, well, I'd like to do one every month, I say to them, so you want your kid crying once a month. I mean, think about it. You can do 5, and they're going to cry the same amount of time, in a sense, as they are for the first one. And if they're really concerned about the pain, then we also do have EMLA. It's something that pediatricians are pretty lazy about doing, but the parents aren't. If you have a parent who's upset and you write a prescription and say, before you come in next time, make sure you fill this prescription, they do it. So I think we just have to give a lot more credit to families than we do.
This has been a great discussion. I'd like for you to please help me thank the panel and also Dr. Ross.
You have been watching a session from the 2006 Pediatric Bioethics Conference, Ethical Issues Related to Vaccination of Children, presented by the Truman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle. For more information about immunizations, please visit the websites listed here or go to seattlechildrens.org/bioethics. The Childhood Immunization Schedule, www.cdc.gov. The Immunization Action Coalition, www.immunize.org. The Influenza homepage, www.cdc.gov/flu.